This video we will be talking about seizures and epilepsy. So firstly, what is a seizure? A seizure is a sudden behavioral change caused by abnormal electrical activity in the cerebral cortex. And the seizure can be divided into different types. The main way to classify seizures is based on whether a seizure is provoked versus unprovoked. So an provoked seizure is a seizure which occurs during or closely in time to a systemic/brain insult. And causes include metabolic problems, drugs and alcohol withdrawal, stroke, encephalitis, and head injuries. Provoked seizures accounts for 40% of all first seizure presentations, and they carry a low future epilepsy risk. However, some patients do progress. On the other hand, unprovoked seizures are not linked to any acute insult, so there is no underlying cause or trigger that can be identified, and they are also called remote symptomatic seizures when it is tied to an underlying disorder. Unprovoked seizures, in contrast to acute symptomatic provoked seizures, carry a higher future epilepsy risk than provoked seizures, with a 21 to 45% chance within the next 2 years of having another seizure after a first unprovoked seizure. So if you have one unprovoked seizure, the chances of you having another seizure is 21 to 45% within 2 years. Epilepsy is a neurological disorder of the brain that is characterized by a predisposition to epileptic seizures. And it has a few definitions, but it can be defined by any one of the following three. The first is having at least 2 unprovoked seizures more than 24 hours apart, having 1 unprovoked seizure with a greater than 60% recurrence risk over the next 10 years, for example, after a stroke or a traumatic brain injury. The International League Against Epilepsy emphasizes the importance of neuroimaging and EEG in the evaluation of first seizures, because some patients with first seizures, depending on the underlying cause, will meet this second criteria for epilepsy after having a first seizure. So for example, a single seizure that happens more than 1 month after a stroke carries a greater than 60% recurrence risk over 10 years. And likewise, a single seizure plus a structural or remote cause plus an epileptiform EEG study also predicts a greater than 60% recurrence risk over the next 10 years. So although these patients have only had a single seizure, because of the circumstances of their seizure or the cause of their seizure, they meet the definition for epilepsy. The third and final definition of epilepsy is that the patient is diagnosed with an epilepsy syndrome, which we will cover in a little bit. Medication refractory epilepsy is when the patient fails to achieve seizure-free control despite using at least 2 appropriate and adequate doses of anti-seizure medications, and it doesn't matter whether or not the medications were used as monotherapy or combination therapy. And status epilepticus is defined as after 5 minutes of either continuous clinical or EEG seizure activity, or the patient has recurrent seizures without ever fully returning back to baseline in between seizures. So 8 to 10% of people will experience a seizure in their lifetime. That's very common. 1 in 10 will have a seizure in their lifetime. What are some risk factors for seizures? The first is age, which is a non-modifiable risk factor, and the risk is highest at the extremes of age. You'll tend to see seizures more in younger people, so children, adolescents, and on the other end of the spectrum in older adults. And compared to children and younger adults, older adults with seizures are more likely to have an underlying cause identified. And so these are the risk factors for seizures in adults. So genetic, so if you have a family history of epilepsy. Lifestyle, if you have sleep deprivation or alcohol intoxication and withdrawal. Certain medications can also lower the seizure threshold, and here are some examples of medications, such as psychiatric medications like antipsychotics, especially with clozapine, bupropion, lithium. And although antidepressants like the SSRI and the SNRI class can lower the seizure threshold, this typically only occurs at toxic doses rather than at the therapeutic doses used to treat depression and anxiety. Tricyclic antidepressants, especially clomipramine, can also lower the seizure threshold at high doses. Antimicrobials are also another class of medications that can lower the seizure threshold. An example would be carbapenems, especially imipenem. Cephalosporins, namely the fourth generation cephalosporins like cefepime, and then followed closely by the third generation ceftriaxone medication. Fluoroquinolones like ciprofloxacin also lowers the seizure threshold, and certain types of penicillins such as penicillin G or benzylpenicillin at high doses can also lower the seizure threshold. So here is a diagram that goes through the causes of provoked seizure, and you can divide it into causes that affect the brain, so causing an acute brain injury, and causes that affect the systemic system, so outside of the brain, and that will be an acute systemic injury. So examples of acute brain injury, you can divide that into vascular causes, infective causes, and other causes, usually trauma. So examples of vascular causes will be things like stroke, whether ischemic or hemorrhagic, a subarachnoid hemorrhage, a subdural hematoma, cerebral venous thrombosis, and posterior reversible encephalopathy syndrome. Infective causes will be things like a brain abscess, a meningitis or encephalitis, and others will be things like acute traumatic brain injury and preeclampsia. Acute systemic injury is usually caused by metabolic disturbances and drugs. So metabolic disturbances can range from a variety of causes such as hypo and even hyperglycemia, hyponatremia, hypocalcemia, hypomagnesemia, hyperthyroidism, elevated levels of elevated levels of urea, such as seen in end-stage renal disease, hepatic encephalopathy, and hypoxia. Drugs, including intoxication by the drugs or withdrawals from certain drugs, can also cause seizures, such as alcohol and benzodiazepine withdrawals. And recreational drugs such as cocaine and amphetamines can also cause seizures. And medications that we've covered before as well, antipsychotics, psychiatric medications, antimicrobials, and also certain toxins and poisons such as lead, mercury, and carbon dioxide. Another cause for brain injury, another cause of seizures that can be localized to the brain will obviously be brain tumors. So let's go through some physiology and pathophysiology for seizures to understand how seizures occur. So seizures occur due to abnormal hyperexcitability from a group of neurons, which will then have hypersynchronous firing. Essentially, there is a lot of neurons that will fire too strongly and too much, and this causes a very hyperexcitable brain. This usually results from an imbalance between excitatory and inhibitory activity, where you have too much excitatory stimulus overwhelming the inhibitory mechanisms of the brain. So what is the normal physiology? So the brain maintains a careful balance between excitation, which is driven mainly by the neurotransmitter glutamate, and inhibition, which is driven mainly by the neurotransmitter GABA. There's a concept called the resting membrane potential, which is the charge of the membrane that occurs at rest, and this sits at minus 70 millivolts, which means that the charge inside the cell is more negative than outside the cells. And this occurs through three different mechanisms. The first is that at rest, the cell membrane is usually more permeable to potassium compared to other ions, as more potassium channels are open at rest, and potassium will then leave the cell down its concentration gradient as there are more potassium inside the cell compared to outside the cell at normal physiological conditions. Number two is that the cells contain negatively charged proteins and anions, and these cannot cross the membrane and so contributes to the negative charge inside the cell. And the third is via the sodium-potassium ATPase pump, which pumps out 3 sodium ions and pumps in 2 potassium ions. So you are losing more positive charge than you are pumping in, and therefore this contributes to an overall net negative charge for the cell. Now we'll cover the action potential sequences for a neuron. And the first step is depolarization. So the neuron's resting membrane potential will sit at minus 70 millivolts, and the neuron will usually be excited by glutamate, causing excitatory postsynaptic potential, so EPSIs. This will cause the membrane to be less negative, and enough stimulation enough excitatory stimulation will bring the membrane potential from minus 70 millivolts to the threshold of minus 55 millivolts. And once this happens, this causes rapid opening of voltage-gated sodium channels, which will cause an influx of sodium ions that will then drive the membrane potential to a peak of a positive charge of 30 millivolts. So at resting membrane potential, negative 70, the sodium voltage-gated channel is closed and the potassium channel is also closed. Positive excitatory stimulus will cause sodium channels to open. It will bring the membrane potential closer towards the threshold potential, making it more positive. And once it hits the threshold, it will cause all of the sodium channels to open, and that will cause the membrane potential to spike upwards and reach a peak of plus 30 by sodium entering the cell. Once the membrane potential reaches the peak of 30 millivolts positive, the sodium channels will close and the potassium channels will open. And the potassium channels will open, and this will lead to potassium leaving the cell, and this will cause the cell to become more negative, and this will repolarize the membrane potential back down to a resting potential of negative 70. However, for a brief period after repolarization, the outflow of potassium is higher than that which occurs at rest, and this is because the potassium channels, once it reaches negative 70 millivolts, which is the resting membrane potential, closes slowly. And so there is an overshoot of potassium leaving the cells, and this causes the membrane potential to be more negative than the normal resting membrane potential of minus 70. And this is known as hyperpolarization. But eventually the outflow of potassium will return back to normal, and the membrane potential will depolarize back to the resting membrane potential via the normal action of the sodium-potassium ATPase pump. And once you hit the membrane potential back to negative 70, then the potassium channels will close and the sodium channels will be ready to be open again. So how does a seizure occur and what are the underlying mechanisms? So the first is, as we mentioned before, is when excitation overwhelms inhibition. So either there is too much glutamate or too little GABA or both, and this causes the brain to be in a hyperexcitable state. A group of neurons, because of this hyperexcitation, will then undergo a large abnormal depolarization, and that's known as a paroxysmal depolarization shift, where they will fire rapid bursts of action potentials simultaneously. The third concept is propagation, where this abnormal firing of the neurons will then spread through neural networks, and if it stays localized, it will result in a focal seizure, and if it affects both hemispheres, then it becomes a generalized seizure. Eventually, there will be inhibitory mechanisms that will terminate the seizure, such as through potassium efflux, with the normal sodium potassium ATPase pump that pumps the potassium out and sodium in, as well as the release of GABA, which is the inhibitory neurotransmitters, and all of these will eventually terminate the seizure. So mechanisms for why a seizure can happen is, for example, there can be mutations to ion channels, such as the sodium or potassium channels, which will make the neurons too excitable. You can have structural brain changes, such as a brain tumor or scarring or vascular malformations that can cause damage to the neurons and cause them to function abnormally. There can be metabolic or electrolyte disturbances like hypoglycemia or hyponatremia that can cause the neuron to work abnormally. And there can also be drugs or toxins that lower the seizure threshold. And there can also be glial cells like astrocytes dysfunctioning, which will reduce the glutamate and potassium clearance from the extracellular space. And so in summary, a seizure is caused by neurons firing too much, too fast, and too synchronously because the brain's normal braking mechanisms are temporarily overwhelmed. So how do we classify seizures? So the International League Against Epilepsy classifies seizures into three categories. There's focal, generalized, and unknown. So focal seizures are seizures that originate in networks limited to one hemisphere, whereas generalized seizures originate in networks across both hemispheres. And focal seizures can be divided into three different categories. You can have focal seizures with preserved consciousness, you can have focal seizures with impaired consciousness, and you can have focal seizures that progress to a bilateral tonic-clonic seizure. Generalized seizures are classified into a few different types as well. You can have absence seizures, You can have generalized tonic-clonic seizures, and there are other types of generalized seizures that are not quite tonic-clonic, such as only tonic, only atonic, only myoclonic, and only clonic. And if the seizure cannot be classified into any of these categories, then they will be labeled as unknown. So the first category is focal seizures with retained awareness, also known as simple partial seizures, and the symptoms will vary from patient to patient, and the symptoms will be determined by which cortical area is disrupted in the brain. Focal seizures typically last less than a few minutes, and as it says, focal seizures with retained awareness, the patient has retained awareness. So they are usually aware of the surroundings and they are able to recall the signs and symptoms of the seizure. And the symptoms, as mentioned before, will be determined by the region of the brain that is affected. So for example, if it occurs in the occipital cortex, it can cause flashing lights. If it occurs in the motor cortex, then it can cause rhythmic jerkings of the muscles of the face, arms, or the legs. If it occurs in the parietal cortex, then that will affect the sensory cortex, and that can cause a distorted sense of spatial perception. And if it affects the dominant frontal lobe, then it can also affect Broca's area, and that can cause speech difficulties. Auras are symptoms of focal seizures without impairing consciousness. So what we mentioned before with the flashing lights and the rhythmic jerkings are all examples of auras. They are simply symptoms of focal seizures where the patient does not have impaired consciousness. The tricky thing about auras is that they can be subtle and can go unrecognized for months. The patient never mentions it. It's something that happens to them and they put up with it. And recognizing aura in the patient's history is very important because it helps to aid the diagnosis of the patient having focal seizures, which in turn will have implications for the treatment with the kinds of which will affect the type of anti-seizure medications that will be used. Auras can be categorized or classified into non-observable and observable auras. So non-observable auras will be ones where it cannot be observed by an outside party. So examples will be psychic auras, which are more common in temporal lobe seizures, such as distortion of time and altered perception, feelings of depersonalizations, feelings of déjà vu, which is feeling familiarity in unfamiliar situations, or jamais vu, which is where you feel unfamiliarity in a familiar situation. Sensory auras, which are more positive symptoms, and this is in contrast to deficits or negative symptoms, which are seen more in strokes. Examples will be a metallic taste in the tongue, a tingling sensation, tinnitus, or colored spots in your vision. Autonomic auras are also common in mesial temporal lobe epilepsy, and examples will be nausea, palpitations, piloerection, so your hair standing on edge, flushing, and a rising epigastric sensation in the abdomen. Observable auras are those that can be witnessed by an outside party. These will be your motor auras, or myoclonics, which are rhythmic jerks, clonics, clonic shakes, and tonic, which is where you have stiffening of the limbs. Speech disturbances such as speech arrest and aphasia can also be affected. In patients with focal seizures, they can also have a post-ictal phase, and the post-ictal phase is different to the post-ictal phase of generalized tonic-clonic seizures. So in the post-ictal phase for focal seizures, the patients may return immediately to baseline, or they may experience a temporary worsening of post-ictal focal deficits. And the post-ictal focal deficits usually depends on the aura or the symptoms that the patient experiences during the seizure itself. So for example, if the patient during a focal seizure has a left arm motor seizure, whether that's myoclonic or a clonic type seizure, they can have a post-ictal focal deficit of a taut paralysis, where after the muscle jerks and shakes, it is followed by weakness, and this weakness can last minutes to hours and can mimic a stroke. There can also be post-ictal aphasia, which can also mimic a stroke or a TIA, and this can create diagnostic challenges with focal seizures often presenting very similarly to a stroke, especially in the post-ictal phase. The next category is focal seizures with impaired awareness, also known previously as complex partial seizures. And focal seizures with impaired awareness is the most common seizure type in adults with epilepsy. and it will involve altered awareness at some point during the seizure sequence, whether that occurs at the onset of the seizure or as the seizure progresses. So during the seizure, the patient will appear awake but disconnected from their surroundings. They have impaired awareness, so they don't respond normally to instructions or questions. They will stare blankly or either remain motionless, and sometimes they can also perform what is called automatisms, which are repetitive automatic behaviors. And examples of automatisms will be things like facial grimacing, gesturing, smacking or chewing of their lips, hand tapping or picking or pointing at objects, or even repeating words or phrases. Focal seizures with impaired awareness, like most seizures, tend to typically last for a short time, so less than 3 minutes or so. And the patient may begin with a brief phase of preserved awareness. Because the seizures start locally, it hasn't yet affected their consciousness. And so the patient may sometimes recall either a aura or the initial symptoms. But the patient will then progress to full impaired awareness, and from this point onward, they will be amnestic to their seizures. The post-ictal phase of focal seizures is characterized by somnolence, confusions, maybe even a headache lasting minutes up to several hours. And the patients will typically, as mentioned before, have no memory of the seizure itself, and they may retain memory of the aura only. Finally, the last classification, or the last type of focal seizures, will be focal to bilateral tonic-clonic seizures, also known as secondarily generalized seizures. So the seizures start locally, but it will then spread to affect both hemispheres. Either type of focal seizures, whether that will be awareness retained or awareness impaired, can spread diffusely to cause bilateral tonic-clonic activity. And the propagation speed is important in focal to bilateral tonic-clonic seizures, because if it is slow, you may have initial focal symptoms visible to the patient and observers before the typical convulsions begin. But if the propagation speed of the seizure is rapid, then it will closely resemble a primary generalized onset tonic-clonic seizure. And this can make it difficult because then, although the patient looks like they have a generalized tonic-clonic seizure, but in actuality they have a focal onset seizure that just rapidly progresses to a generalized seizure. In both cases, patients are often amnestic to the initial focal phase because of the generalized seizures effects. So if the seizure becomes generalized and it starts to impair and it impairs their consciousness or awareness, they typically will not be able to recall what has happened. And there are certain clues that suggest that the seizure may be focal in origin versus generalized, such as if the patient has a seizure or aura preceding the event, because if you have an aura, it typically means that one part of the brain is affected. If you have post-ictal focal deficits, such as thought paralysis that we mentioned earlier, because then it suggests that it started off in one part of the brain, if the post-ictal deficits are focal, affecting one part of the brain. If you have a history of structural brain injury, so if you have a brain injury in one part of the brain, then perhaps that part of the brain will be affected with the seizure. And if you have focal findings on neuroimaging or EEG. Next, we move on to generalized seizures. So generalized seizures are seizures that originate from both hemispheres. And the key thing to know is that generalized seizures, new onset generalized seizures, is uncommon in adults. So in adults, it's usually, if they have a tonic-clonic seizure, it typically will be focal in onset, which then progresses to a generalized seizure. Most unprovoked generalized seizures in adults are actually secondarily generalized from a focal onset. And so this is because the symptoms of the focal phase can be very subtle or brief, and such they are missed. And so the only thing you really notice in that patient is the obvious tonic-clonic shakes, but the symptoms of the focal phase will be there at the start, which can be difficult to pick up. And the symptoms can be so subtle and so brief that even the patient may not have any recollection of it prior to the loss of consciousness. But in generalized seizures, the patients will usually present with an impaired consciousness. Here are 6 categories for generalized seizures, and main ones. There are more than 6, but I will only cover 6 due to time constraints. The first is the generalized tonic-clonic seizure, also previously known as a grand mal seizure, where the patient has an abrupt loss of consciousness, sometimes with a scream or choking sound. They then proceed into a tonic phase where all their limbs and trunks will stiffen, and they may have a forced scream or cry during this phase as the epiglottis shuts tightly. They then will proceed into the clonic phase, where they will have rhythmic jerking of the limbs, and in this phase they can also have tongue biting or frothy or blurty sputum because of the tongue biting. They may have cyanosis, foamy salivation, and possibly also bladder or bowel incontinence. They will then enter the post-ictal phase, where they will have a deep sleep with gradual awakening, and this will then proceed into a period of confusion, agitation, and sometimes they may also have headache, fatigue, and muscle aches. The next type is absence seizures, also previously known as petit mal seizures, and they occur mainly in childhood, where they last 5 to 10 seconds, but they can occur hundreds of times a day, and it is characterized by sudden behavioral arrests with a blank stare and impaired consciousness. And if it is more than 10 seconds, they may also have eye blinking and lip smacking as automatisms. Myoclonic seizures are sudden brief involuntary muscle contractions which can occur in single or in clusters, and it can affect any muscle groups, but typically affecting the arms, and consciousness can usually be preserved. In clonic seizures, you have rhythmic jerking of the arms, necks, and face. In tonic seizures, tonic means tone, so you have an increase in muscle tone, and so the muscles will be stiff, and patients will usually have impaired consciousness, and this can lead to falls. And another type of seizure that can cause collapse and falls will be atonic seizures, which is the opposite of tonic seizures, where you have a sudden loss of muscle tone. When the legs give way, they collapse, and this can also lead to a risk of injury. Important to note that clonic, tonic, and atonic seizures are rare, and they mainly affect children with epilepsy syndrome, such as Lennox-Gastaut syndrome. They are rare in neurologically normal children and in adults with new onset seizures. So here is a table which compares and contrasts focal and generalized seizures to try and help understand whether or not the patient will have focal or generalized. So the first factor is the type of onset, which you can't pick up clinically. And focal seizure starts with the type of onset. Focal seizures start in one region of the brain and it may spread, whereas generalized will start in both sides of the brain on onset. The level of consciousness in focal seizures can be impaired or preserved, whereas in generalized it is usually impaired. In terms of the features of the seizures, focal will have auras such as, automatisms and motor auras which are observable or non-observable, such as the cognitive, psychic, emotional, sensory, or autonomic auras that we covered before. Whereas generalized seizures tend to be more muscular in nature. So tonic-clonic, myoclonic, tonic, atonic, clonic, and of course the absence seizures that happen in children. For focal seizures, it is typically the first seizure in patients above 65, whereas generalized seizures tend to occur more as a first seizure in patients under 20 years. And focal seizures can happen after an acute insult, so it's more likely for a provoked seizure to be a focal seizure, such as after a traumatic brain injury or a stroke, whereas for generalized seizures, they are typically unprovoked. And so with focal seizures, you may find things like structural lesions on imaging, whereas you may not find anything for generalized seizures. Tonic-clonic seizures that occur during sleep also hints at a focal onset, whereas in contrast, generalized seizures are tonic-clonic seizures provoked by sleep deprivation. So they occur when they're awake as a result of sleep deprivation rather than when they're asleep. And for generalized seizures, they do not have any warning symptoms before the loss of consciousness, whereas in focal seizures, they may have auras or warning symptoms that the patient may be able to recall before they have impaired consciousness. And for focal seizures, the symptoms may be focal or asymmetrical, whereas in generalized seizure, they typically will have bilateral involvement of the limbs. So next, we will talk about briefly the different types of epilepsies and their classification. So the first type of epilepsy is called genetic or idiopathic generalized epilepsy. And this accounts for about 20% of all cases of epilepsy, and it usually starts early in life, so in childhood or adolescence. And it is characterized by a combination of absence seizures, myoclonic seizures, as well as generalized tonic-clonic seizures, and the EEG will typically show a generalized pattern of spike and wave discharges. There are 4 types of syndromes which fall under the category of genetic or generalized epilepsy, and this will be childhood absence epilepsy and juvenile absence epilepsy, which differs based on their age of onset, with childhood absence being in childhood and juvenile absence being in adolescence. We also have juvenile myoclonic epilepsy, which is the most common genetic generalized epilepsy, with a peak onset at 13 to 16 years of age, but it can also occur in adults contrary to its juvenile name. It is characterized by myoclonic jerks, which usually occurs shortly after waking and with sleep deprivation. And these are bilateral irregular jerks, usually of the shoulder and the arms without any loss of consciousness. And it can occur before a generalized tonic-clonic seizure, but these myoclonic jerks can also go unrecognized. In JME, they will also usually have generalized tonic-clonic seizures and sometimes absence seizures. And so with these syndromes, there is a mixture of different seizure types. And the last type of idiopathic generalized epilepsy is the epilepsy with generalized tonic-clonic seizures alone, where, as its name suggests, it only has generalized tonic-clonic seizures. The next will be focal or partial epilepsies, and these can be classified based on their specific etiology, such as mesial temporal lobe epilepsy with hippocampal sclerosis, and it is characterized by a rising epigastric sensation, a sense of fear, and oral automatism such as chewing or lip smacking, altered consciousness, and post-ictal confusion. So a type of focal seizure with impaired awareness. Frontal lobe epilepsy is characterized by brief stereotypical sleep-related seizures with motor agitation, hyperkinetic movements, and a frightened arousal from sleep. And you also have temporal lobe epilepsy, where the patient will experience experiential phenomena such as déjà vu or jamais vu, a sense of fear. They may also have oral automatisms, like what you would see in mesial temporal lobe epilepsy, as well as olfactory and gustatory hallucinations, and perhaps also an absence-like staring. There are also self-limited focal epilepsies, and these usually occur in kids, and as its name suggests, is self-limiting, usually remitting by adolescence. An example of a type of self-limited focal epilepsy is self-limited epilepsy with central temporal spikes on EEG, and this is characterized with an onset in mid-childhood, so primary school age, and the seizures usually occur during sleep, and they start in the face or a mouth with a typical glogging sound, and speech arrest is common, and the EEG will show epileptiform discharges in the central temporal region. This is a type of epilepsy with good prognosis, and most are seizure-free by early adolescence. Then you'll have the developmental and epileptic encephalopathies, and these are a group of epilepsies in patients with a brain disorder that can occur from a genetic, structural, metabolic, immune, or an infectious cause. And these epilepsies are often present very early in life, and they present with very severe epilepsy. And they will typically persist into adult life, and they are associated with very difficult to control drug-resistant seizures. So severe epilepsy, bad prognosis, very difficult to control seizures. And there are a few examples, which we will go through 3 of them. The first is Lennox-Gastaut syndrome, and the causes could be due to structural brain abnormalities like a tumor. They can be genetic or chromosomal mutations. There can be acquired brain insults, such as from infections of the brain or the spinal cord, or hypoxic brain injury, or if the patient has a prior history of West syndrome, which we will touch on in a bit. The characteristic clinical feature of Lennox-Gastaut syndrome is onset of seizures during childhood with significant intellectual disability, and the EEG pattern shows a characteristic generalized paroxysmal fast activity with slow spike and wave discharges. And it is characterized by multiple different seizure types, including tonic, especially in sleep. You can have atonic drop attacks, atypical absence, and tonic-clonic, as well as myoclonic. The next example of a developmental and epileptic encephalopathy is Dravet syndrome, also known as severe myoclonic epilepsy in infancy, and it is caused by usually a mutation in the SCN1A gene, which codes for a sodium voltage gated channel, but it can also be idiopathic. Dravet syndrome carries a high risk of status epilepticus and SUDEP, which is sudden unexpected death in epilepsy. And the characteristic clinical features of Dravet syndrome is that the onset is in the first year of life, and the patient will have prolonged febrile or afebrile generalized tonic-clonic or hemiclonic seizures, which will then progress to develop multiple additional seizure types such as myoclonic or atypical absence seizures. Dravet syndrome is also characterized by normal development in the first year of life before then progressing into intellectual disability by the second year of life. So it's progressive. The seizure type will progress from a generalized tonic-clonic seizure before developing additional seizure types, and you'll have normal development before progressing to developing intellectual disability by the second year of life. The next one will be infantile epileptic spasms syndrome, or IESS, or infantile spasms, and there is a subtype of IESS called West syndrome, where it is defined by the presence of a particular triad of findings. Common causes of infantile spasms will be focal structural abnormalities. They could have some sort of hypoxic insult during the perinatal period or due to tuberous sclerosis complex. The onset is in the first year of life, peaking at about 3 to 7 months of age in incidence. And if they have a characteristic triad of epileptic or infantile spasms, Hips arrhythmia on EEG, and developmental arrests or regression, then that patient will have West syndrome. In terms of the infantile or epileptic spasms, these are brief, usually for a couple of seconds, bilateral and symmetrical contractions of the neck, trunk, and the limbs, and this can affect flexor muscles or extensor muscles or a mix of both. And they occur in clusters, so usually 20 at each time, and they can occur multiple times throughout the day. And they will frequently occur after waking from sleep, and the baby will usually have an associated cry indicating they're in distress. The EEG, as mentioned, will show Hips arrhythmia, and they can lead to developmental arrest or regression. And in the majority of patients, the developmental delay actually occurs before the spasms occur, but it may not be that noticeable. An example will be a loss of social smile, social withdrawal, or a loss of visual attention. And when these onset of the spasms occur, they will then typically progress into developmental regression. Okay, so infantile spasms, Hips arrhythmia on EEG, and developmental arrest or regression.